My name's Ed Beveridge. I'm a psychiatrist and a medical director in North West London, and I've got a long-standing interest in improving health of people with mental health conditions, and it's really exciting to be here to talk about the topic of lung cancer screening and diagnosis. And I'd like to introduce Adam.
Hi, yes, my name's Adam Januszewski. I'm a consultant oncologist and I care for patients with lung cancer. And over the last few years, I've been involved with trying to reduce some of the inequalities in access in treatments for patients with lung cancer. And that's why individuals with mental health conditions are so important, because we know that that there is such a large variation in care access.
And we worked together on a report that's now publicly available, and that was looking at improving diagnosis of lung cancer in people with particularly severe mental health conditions. And we had involvement from Rethink Mental Illness, who are a charity who do a lot of work around lived experience involvement in different healthcare pathways. It looked really at how we improved access to screening programs and diagnostic pathways. And it's produced a number of really good recommendations.
Not only are they practical recommendations for on the job if you work with individuals with mental health, but also system level recommendations on how to redesign or think about designing services to enable us to provide the best outcomes for individuals with mental illness and potential diagnosis of lung cancer.
Can you say a bit about what's your part of the pathway for lung cancer?
Lung cancer is really exciting to work in at the moment, because we've seen such great advances both in the screening, the diagnosis and the treatments for lung cancer. And the issue around inequalities is becoming even more important, because while we're getting better treatments and outcomes, we don't want that inequalities gap to widen. And that's where we were involved in bringing together a group of experts from across the UK to look at some of that data around the inequalities in access and outcomes for patients with lung cancer. And what we could see is that those individuals with severe mental illness have some of the lowest outcomes or poorest outcomes compared to their compatriots that don't have mental illness. And that's a really important point, because there's no point in improving all of these processes if we're not including those individuals who are most affected by it.
My understanding is that people with severe mental illness, so things like schizophrenia or bipolar disorder, don't get diagnosed early enough to get good outcomes. Is that right? What
we know is that diagnosing early improves outcomes. When we look, and that's why the lung cancer screening program has been rolled out over the last 2 to 3 years. What we've seen in some of that data is that around 3/4 of patients that are diagnosed with lung cancer through the screening pathway are diagnosed with stage 1 or 2, which means they're able to have curative intent treatment. Now, when you look outside of the screening pathway, only around 1/3 of patients are diagnosed with early stage lung cancer. When we look at the proportion of patients with severe mental illness, they are more likely to be diagnosed either through the emergency route or indeed with a more advanced disease, which means that we can't offer radical or curative intent treatments for those individuals.
And we see that across all sorts of disease areas. There's a recurring theme of late diagnosis, worse access to treatment, worse outcomes. And I think, the point I've made in all sorts of forums is that our pathways are designed for the general population. And I'd like to come back to talk about yours in a sec. But the other thing that occurs to me is, of course, preventing smoking or stopping smoking is probably the upstream intervention that we really need to make sure that people have access to. And I think this is a lot of what the work that I've been doing is looking at as well, and clearly getting people screened earlier so that they can come into treatment at a stage where their cancer is treatable. Say somebody has symptoms suggestive of lung cancer, what would their pathway through to diagnosis look like?
So in order to be diagnosed with lung cancer, there are in general 2 pathways. As we've spoken about, there's the screening pathway. If you are between 55 and 74 and you've ever had a smoking history, whether that's current or previous, then and you're registered with the GP, then you're invited to what was called a lung health check. That involved a series of questions about lifestyle and risk factors, And then if they meet certain criteria, will be invited for a CT scan. That CT scan is then performed often in a local environment, sometimes in a car park of a supermarket. And then the results go back to the patient, and all being well, then they'll continue in that program. Every 2 years, they'll be invited back to that. Now, we can talk a little bit about why it's more challenging for people with severe mental illness to engage, to be invited to work through that screening pathway. But I suspect that is reflected in many of the other cancer screening that we see.
Various things about screening programs that can accidentally exclude our patients. So for example, it's based on communication to your home address.
Yes.
If you're in long-term hospital, or if you've moved, those are the sorts of things that mean you might miss out. But also, people with mental health conditions quite often find it difficult to open post or respond to phone calls from people that they don't know. So there is a bigger risk that they won't take up the offer of screening. There isn't very much by way of recalling people who don't turn up to screening, I think.
Lung cancer is one of the conditions or malignancies that has the greatest impact around inequalities, but also affects the most diverse and deprived communities in the UK, is that there's been a real proactive approach to try and reach out to engage with all of the deprived and diverse communities in the UK, but they've not looked at those individuals with mental health conditions. And while we've got some great uptake across the UK, I don't think we're tracking individuals with mental health illness within that pathway to understand how well we're doing. But B, I don't think any of those pathways have been designed. While we've engaged with patient and advocates, we haven't done the same with individuals with mental health illness. And I've always said, if you can design a pathway for either the most deprived, diverse individuals with mental health conditions, if you can design a pathway for those individuals, actually it makes it better for all people.
From your clinical experience, what's it like for people with a severe mental health condition coming into a diagnostic pathway? What happens to someone in that position?
Lung cancer is really complicated. In order to get a diagnosis of lung cancer, there are so many steps, from scans to biopsies to lung function to meeting different doctors, nurses, physicians, to go through that without a condition of mental health illness is complicated in itself. And actually what we know is that it can be quite overwhelming for patients. So from presenting to your primary care physician or through ED with the symptoms, that barrier is building up that courage to report those symptoms. Individuals who have smoked in the past often attribute their symptoms to just smoking. What we know is that because of the increased likelihood of developing more advanced lung cancer, our diagnostic threshold should really be lower for individuals with mental health conditions. And so we shouldn't really be saying come back, and if it's not gone away within 2 weeks, we should really be kind of moving on and through that diagnostic pathway. But then there's serial appointments after appointments and scans after biopsies, which if you get through right to the end, it is actually an achievement in itself. And what we often find is that the engagement and the attending of all those appointments is more difficult because each of those appointments is a barrier in itself, and people drop off and don't engage the more tests. And what you know is that sometimes people don't understand how important every single one of those steps is, because if you don't do every one of those steps, I can't give you a formal diagnosis and treatment plan. And as an oncologist, I sadly don't see many people with severe mental illness because, as I said, the amount of barriers to get through that diagnostic pathway, but also I think there's a preconception amongst physicians that to engage with the treatment for lung cancer can be really complicated and is potentially of higher risk, because if an individual is unable to seek help, if they don't have the support that is required, then they may not be able to be offered the treatments that they need, which would be the best treatments. And I think one of the things that we really need to work on is trying to educate, upskill clinicians that work in the lung cancer field, so that there aren't those preconceptions, so that we give patients with mental illness the best treatments with the support that's required.
Those preconceptions we know aren't true, because if you speak to people with lived experience, there's no evidence that they don't want the same treatment options as everybody else. If you look at smoking cessation treatment, for example, the evidence around that is that people with mental health conditions want to stop smoking, will engage with support if it's designed for them, and will be successful in quitting. And I think one of the messages that I think it's really helpful for us to put across is the fact that, you know, everyone wants access to the right treatment for what they have.
Yeah, and it's about clinicians that work within the lung cancer kind of pathway, whether that's the diagnostic or the treatment pathway. I think we have a lack of confidence and understanding about how to care for patients with mental health conditions. So I think there's a need to improve that understanding. I think there's a need to work together more closely. Like you said, I don't know who to contact, who's the key worker, does what types of patients with mental illness have a key worker, and at what point I should be engaging with them. So I think there's something about working together to be able to support the patient in the best way possible.
And when you start having those conversations between you, everyone really wants them, you know, so it's not just us two, but actually as soon as you start discussing your patients with people from different parts of the system, everyone really wants to do that, because it will get better outcomes for the people that we work with.
Language is really important, particularly in patients with a potential diagnosis of lung cancer. When we look back at the first pilots for the lung cancer screening, it was called the Targeted Lung Health Check. And that was because there was patient feedback, or PPI feedback, that calling something a cancer screening pathway is fearful, and therefore there was a fear that there would be a lack of engagement with that. And I still find that true. Now, they've switched the language to the lung cancer screening pathway, and that's a government-directed change in name. But my fear is that for individuals with mental health illness, that labelling this as a cancer check may create barriers that it doesn't need to, because actually it's about raising awareness around well-being, around your lungs, around smoking. I mean, what do you think?
I think what people with lived experience say is that scare tactics don't work, and we're very good at saying you shouldn't smoke because X, Y, and Z thing will happen, which is true. But I think what we don't do well enough, and where it really helps to have people with your type of expertise on board, is the message should be, if we do these checks, we can treat whatever's there. So and we can give you support to stop smoking if you're still smoking. And I think we don't give enough of the positive messages about what can be treated, because we're too busy giving the negative ones about what could go wrong.
What we see is through the lung cancer screening is that we have positive health impact just through the program, not only because we diagnose lung cancer earlier, but actually having those conversations with individuals about smoking cessation and positive lifestyle changes actually has longer term impacts as well. And as you know, it's not just about lung cancer. Actually, smoking has many other health-related conditions, that's ischemic heart disease, COPD. So actually there's many opportunities there for those conversations and about lung cancer, about smoking, from all sides of the spectrum. That's primary care, that's individuals in secondary care, and also from a mental health background.
It'd be good to talk about what the solutions are, because there are lots of ideas in the report and lots of things we can think of. And rather than focusing on screening per se, it'd be really good to think about the diagnostic and treatment pathways and what could change there. And we've talked a little bit about, you know, mental health expertise in your pathways, but what else do you think could change to change the outcomes for people?
There's a few things that could be done. To start with, I think we need to give the tools and the understanding to individuals that work and care for patients with mental health illness, whether it's their key workers, whether it's their primary care physicians, so they can have the discussions around lung cancer screening, smoking. Beyond equipping staff, whether that's in primary care or in mental health services, with the tools to discuss smoking screening, smoking cessation. I think fundamentally we need to rethink and design our diagnostic pathways with patients with severe mental illness in mind, whether that's the number of appointments they get, whether that's how they're communicated with, whether that's how we engage with their carers and supporters, to be able to facilitate patients. There are examples around the country where you have one-stop clinics where you can have several tests at once, or indeed for other people you need more time between those tests, because actually you do need to take a personalised approach to the diagnosis of lung cancer. But I think if you improve it for individuals with severe mental illness, actually taking that patient-centric approach, actually you can improve the pathway and experience for patients regardless of their background.
What other things do you think we need to change? There's the idea of integration between services, and that happens at, I think, different levels, because there's staff working in each other's pathways and having better communication with each other. But I think there's also sort of structural things and things like data, I suppose. What do you think about that?
To make a real difference, I think integration of physical and mental health during a cancer diagnostic pathway and treatment discussion is fundamental, because these are complicated decisions to make. And unless you've got the trusted individual that the person or the patient has in those discussions, then you're not going to be able to make an informed decision and actually make the best decision. I would like their key worker in the consultation with me. Have I ever seen that? No. Should we? Yes. So I think there are some parts of that whereby there's probably upskilling of some of the oncology staff, the clinical nurse specialists, who are often the point of contact, and maybe working more closely together with key workers, so that there's more of a seamless trust. Because often if patients or individuals with mental health conditions know that their key worker trusts their care team that's going to look after them, and ultimately all of the changes or differences that need to happen, we need to be able to track. Everything is about tracking and KPIs, because actually we don't know if we are improving or deteriorating. As I said earlier, the treatments, the diagnostic and screening, are improving in lung cancer, but we don't want to widen that gap. We don't want to leave kind of individuals from diverse backgrounds behind, and therefore it's important that we track that with data. It's fundamentally important that we integrate services and we communicate closely, but ultimately, if we're going to close that gap and improve the care and outcomes for patients with lung cancer and severe mental illness, then we need to track that data and integrate it from primary care, from mental health services, and to secondary national data.
And I think there's a real opportunity to do that at a population level as well, so that we're actually proactively finding people who are at risk and proactively reaching out to them, because it's not something we do very well at the moment. But actually, if we're going to solve that problem of late diagnosis, then finding the people who are at risk of it, using the data we've got and improving the quality of the data we've got, I think could make a real difference as well.
One of my take-homes from the report is actually there isn't a single solution. There are a multitude of solutions, from individual basis up to systems level, and it won't be one thing that resolves this, but lots of different things. And having that personalised approach for the patient that's in front of you ultimately will improve the long-term outcomes for these patients.
And for me, that makes it feel more manageable, because actually you're not looking at one enormous change, you're looking at lots of small changes at different parts of the system. And I think if you sort of look at the pathway and the system in that way, you can see potential for, small changes everywhere that will add up to something that hopefully changes outcomes in the longer term.